which we're talking about lesions that are found in the mouth. So we have the next group of lesions, which is reactive connective tissue hyperplasias, and these are these are lesions that are grouped together based on their ability to have overzealous repair. So they're trying to repair themselves too quickly, and it causes a whole nother issue. So again, reactive connective tissue hyperplasias. A little in depth about the group of lesions. They're from an overgrowth of granulation tissue, can be caused by chronic inflammation, which is healing that just goes wrong, and it also may be a response to a single event or chronic low-grade injury. So basically something happens and causes a lesion, and the lesion tries to repair itself, and it goes crazy. Let's review real quick what granulation tissue is. It's new tissue formation in connective tissue around the injury. It's the proliferation of capillaries and fibroblasts. So these are the culprits of the lesions in this group. There are 7 lesions. So here we go. Gingival enlargement. Gingival enlargement is an increase in the bulk of free and attached gingiva, especially in the interdental papillae. Basically, the gum tissue gets really bulbous and round and inflamed and large, and it turns from pink or pale to really, really red depending on the degree of inflammation. And it can be generalized, and it can also be localized. And it can happen in the free gingiva, attached gingiva. So yeah, gingival enlargement. Usually, an unusual tissue response of gingival enlargement happens to chronic inflammation associated with irritants such as plaque or calc. So for example, gingivitis could be a chronic inflammation or gingival enlargement. We also know the gums can get big due to local tissue factors such as hormone changes in pregnancy or puberty and certain drugs. What are the drugs that cause gingival enlargement? Phenytoin, however you say it, calcium channel blockers, and cyclosporin, which is an antibiotic. How do you treat gingival enlargement? Well, there's 2 different things that can happen. You can have a gingivoplasty, which is when the dentist goes in and reshapes the gingiva, or you can have a gingivectomy, which is removing the gingiva altogether, the area that's inflamed. Sometimes we need the tissues to go under a biopsy to rule out gingival enlargement seen with leukemia, because that can be a sign or a symptom of leukemia, and if that is the culprit, then we want to know that versus going in and removing gingival tissue only to realize it's going to be affected later. There's a lovely example of that. Pyogenic granuloma. So this is a proliferation of connective tissue containing numerous blood vessels and inflammatory cells, occurring as a response to injury. Now, when we talked about thinking of the names of the lesions to help you out, this one is not going to help you out because it's the opposite. So, pyogenic, it's not pus forming, and granuloma, this lesion is not a true granuloma. This is known as the pregnancy cyst that we talked about in class. It's a large, localized red area of overgrowth of tissue. It usually happens to pregnant women who do not properly remove plaque, and then the hormones go crazy and cause a cyst. But we also see it in teenagers who are also having an imbalance of hormones. The lesion is usually ulcerated, soft to touch, and bleeds easily. It can be deep red or purple, but either way it looks super inflamed. It's generally raised or elevated. It may be sessile, which is flat and broad, or pedunculated. Most commonly it's seen on the gingiva. Many may vary in size. And then just remember, if you see it on a pregnant person, it's called a pregnancy tumor. But how do you get rid of it? You surgically excise it if it does not go away on its own. So there it is again. Remember, it's a localized, large growth of reddish purple tissue. Okay, giant cell granulomas. a lesion that contains many multinucleated giant cells, well vascularized connective tissues, red blood cells, and chronic inflammatory cells. Giant cell granulomas originate from the PDL or the periosteum in response to injury. So you have two types of these. You have peripheral giant cell granuloma, which occurs outside the bone, and then central, which occurs inside the bone. So how are you going to remember that? Well, peripheral means on the side, so just think peripheral of the bone, outside of the bone. Central is within, or the center, so within the bone. So let's break those two down. Peripheral giant cell granuloma. This one occurs on the gingiva or the alveolar process. Usually we see it anterior to the molars. It's a response to injury. It can vary in size. Usually it's dark red. Most people are seen with it from 40 to 60 years of age, and it's more common in women than men. And obviously the way to get rid of it is to excise it, because remember, it's outside of the bone. So there's a picture of it right there, peripheral giant cell granuloma. And be careful with this one because it's very similar to pregnancy cysts. It looks a lot like it. Then you have central giant cell granuloma. This occurs within the bone. It's most frequently in children and young adults, more common in females than males, and pain is not a common feature of it. Usually we discover this through radiographs because, again, it's inside the bone, so that's the only way we could see it. The lesion can be uniocular or multilocular, and it may cause divergence of roots of adjacent teeth. How do we get rid of this one? Well, we also have to use surgery. So, like we said, you can only see it in a radiograph. So there's an example of a radiolucent area growing inside the bone. Okay, irritation fibroma. This is the most common mass seen on the gingiva. It's broad-based, dense, scar-like connective tissue with few blood vessels, and it results from trauma such as cheek chewing or cheek biting. It's usually small, and it most often occurs on buccal mucosa, but it can also be seen on the tongue, lips, and palate. Linea alba is also a type of this. So again, irritation fibroma. Very, very similar to frictional keratosis, except it's a broad-based lesion. And for this, you also need to surgically remove it. Okay, epulis fissuratum, aka denture-induced fibrous hyperplasia. This is observed in the vestibule as elongated folds of tissue that an ill-fitting denture fits into. The surface becomes ulcerated from the denture. Basically, this is what you get when you do not remove your dentures for a long time. This kind of fibrous hyperplasia that's going on. To treat it, you need to surgically remove the excess tissue and also make a new denture. There's an example of it right there. The denture is pinching on the tissue, causing a growth around the denture base, and it's very uncomfortable. Okay, papillary hyperplasia of the palate, or palatal papillomatosis. Almost always associated with a removable or partial denture. This is also known as denture-induced hyperplasia. But basically, the palatal vault is covered by multiple papillary projections. So this is the lesion where you have a bunch of projections sticking outward of the palate. Each projection is fibrous connective tissue, usually chronically inflamed, and the cause is unknown, but we know that it can usually get infected with Candida because they're long projections, so the bacteria can settle in there. To treat it, you have to surgically remove the projections prior to making a new denture. This is why patients should take their dentures out at night, because it's like wearing your socks and your shoes every day. Your skin will ultimately change on your feet. Also, your palate will also change. So here's a picture of it. You can see the little projections sticking out. So again, just think of it this way. You got two denture lesions that we're talking about. The one that has to do with projections starts with the P. Has lots of P's in the name. Papillary hyperplasia of the palate, or palatal papillomatosis. And there it is again. It kind of looks like cobblestone, as it was stated in the book. Okay, then you have chronic hyperplastic pulpitis, which is a pulp polyp. This is an excessive proliferation of chronically inflamed dental tissue in the pulp. You see this in baby teeth and also young adults. Basically, in the teeth, they have a large carious lesion, and the pulp breaks through the crest of the enamel and swells. Both primary and permanent molars can be affected. It's usually asymptomatic, it doesn't hurt. It can be related to the large root opening and blood supply of the tooth that it's happening in. And pretty much it's granulation tissue that's primary. To treat it, you have to extract the tooth or perform a root canal. Why is it asymptomatic? Let's think about that. Well, because the hyperplastic tissue contains so few nerves, so there's not really much nerves going on. But there it is. We talked about the pulp starts to come out of the occlusal surface of the tooth because the layers of the baby teeth are thinner. So that is chronic hyperplastic pulpitis, or a pulp polyp. Okay, and then that concludes our section talking about connective tissue, or reactive connective tissue hyperplasias.